you notice, the title of the talk was Heuristic Answers, and heuristic means experience-based. Over the last 35 years, I've been asked questions at meetings which pertain to the fractures of the distal radius when I travel all over the world. And there is a common theme in all these questions, and those are the questions that bother all of us. And we ask ourselves and we ask our colleagues, and the answers that I've come up with have been those which are experience-based. In addition, for each of these questions, I'll try and give you also a reference or a piece of work that I have done, which will help to kind of make the case a little stronger for what I'm recommending. So here we go. I don't have any disclosures that pertain to this talk. I'm really grateful for the learning that I've acquired from my patients, and I really don't consider myself a master in this, but a lifelong student. So if I had to say one thing to the audience that is listening, I would say that please don't approach the distal radius as one block. It should really be considered as 3 columns. This columnar concept was popularized by Ripley and Regazzoni about 20 years ago, and it's important to look at it as the radial column, the intermediate column, and the ulnar column. Once you look at it as these columns, you'll also realize that there are fragments which are specific to these columns, and then only then can you understand what is the real way of approaching these fractures surgically. Now, mind you, this talk does not deal with non-operative treatment. We are really going to focus only on answers to commonly asked questions regarding surgical treatment. So the first thing that I would be asked is, what anatomical features to me are really the most critical? Now you will see on your screen that there's a black line going across the distal radius, just proximal to its articular surface. You should call that the equator of the distal radius. And if you look at my cursor, you will see that the green arrow points to the overhanging radial styloid, which is infraequatorial. That means that if you were to place any implant from the radial styloid and I try to achieve a purchase proximally, then it has to be directed dorsally as well as ulnarly. It cannot be going straight across because it won't achieve purchase. So that's the first thing. The second thing is, here in this picture on the left, you will see that the styloid has a bare area near its tip. So if for any reason your K-wire were to go through this bare area, don't be too concerned because it is non-articular. Now, what other features do we think about anatomically? You have to think about the lunate facet. Now, the lunate facet by itself extends volarly, distally, and ulnarly. It is not coplanar with the rest of the distal radius. And that is really critical to understand because, as you know, and as Dr. Ravi Gupta said, that this is your watershed line. And if you look at the lunate facet, it extends volarly, ulnarly, and distally. So if you were to place any implant here, it is very unlikely to capture this. More importantly, it is important to know that the short radial lunate ligament that you see here is very much attached to this lunate facet fragment. And this is something that you really will understand is responsible for displacement of the corpus if the lunate facet fragment displaces. But we will cover more of that a little later in the talk. So those were the anatomic features. Fragment, understanding that there's columns, understanding which fragments are important and which can burn you if you don't pay attention to them. So that being said, now you have to know, once you know your anatomy, you got to go to your radiography. So the key radiographic characteristics in my assessment are not just the radial length, ulnar tilt, radial tilt. Those are standard. You know about those from regular textbooks. Those that are not emphasized are what we call here the teardrop angle. The teardrop angle is really a surrogate for the volar inclination of the lunate facet, i.e. the volar inclination or extension of the intermediate column, and that is very underappreciated. The teardrop angle is normally about 65 to 70 degrees, and it's measured as shown in the picture on the right. And if the teardrop angle increases, as you can see from this X-ray below, usually indicates that there is a shearing injury of the volar margin, either just the lunate facet or the entire volar margin. In such injuries, if at all available, a CT scan must be done. The other thing that we don't pay too much attention to, and which is perhaps difficult to see in plain radiographs, is the AP distance, which is basically another surrogate for the intermediate column between the volar and the dorsal margins of the intermediate column. Now, as you see from this X-ray, the teardrop angle has reduced, and the AP distance, which is measured from here to here, appears quite large. AP distance does have a finite measurement. It's about 21 millimeters in men and 17 to 18 millimeters in women. But then again, these are finite numbers which you have to take with a grain of salt, because someone who's 6'10" may not have the same distance as someone who's 5'2". But those are broad guidelines. If the AP distance is increased, usually indicates impaction injury to the intermediate column, and that is usually accompanied by a depressed teardrop angle. The final radiographic parameter that I pay attention to is the dorsal lunate corner of the radius, which is correctly known by Max Scheck in 1962 when he described it as the die punch fragment. So the die punch fragment is really critical to understand. It's the dorsal ulnar corner of the distal radius, not any part of the distal radius. The dorsal ulnar corner is the die punch. Now, why is this die punch so important? Well, we know from Greg Bain's studies that, and in the picture that I showed you before, that the ligaments around the distal radius have a specific attachment. At the point of attachment of the ligaments, because of Wolff's law, bony density is high. Between attachment of ligaments, bony density or trabecular density is low. Therefore, fracture lines propagate in between ligamentous attachments usually, and as Malone pointed out to us nearly 30 years ago, these fracture lines propagate in a very predictable manner, and you get these four fragments, which are largely the main components of any articular fracture. Only thing that differs is how big are they. So once you understand this fragment geometry, based on this attachment of the ligament complexes, it becomes very easy to understand radiographic parameters and also to fix them. Okay, we know the anatomy, we know the x-rays, we know where the ligaments are attached. So when do I get a CT? If I see an increase in AP distance, or if I see a change in the teardrop angle, I will get a CT. All high energy injuries get a CT. If I see a scaphoid impression fracture, I will get a CT, or if I see associated carpal injury, which I suspect. Scaphoid impression fractures are very unique injury, which I'll talk about a little later. So let's look at this. This is someone who fell off a roof about 10 or 15 feet. And when you look at an x-ray like this, you don't really get a sense of what's going on. So this is an ideal situation where you get a CT. But then you get a CT and you ask yourself, hang on a second, do I really have more information because the CT is so displaced and I really have no clue of what's going on? So this is a good indication to stop and take a break and say, okay, hang on, can I get more information if I restore radial length? Because we know very recently in the last 5 years, we have studies published in the JBJS which have shown that traction radiographs of the wrist, if obtained in the emergency room and if compared to CT scans, can be almost as valuable to the operating surgeon in deciding how to fix the fracture and where to place the implants. So if you don't have access to a CT, you don't have to be concerned. Obtain traction radiographs and they can be just as good. But to get traction radiographs, if you can't get it in the first day, then you have to do it in the operating room and you have to restore length. How do you restore length? For me, I release the brachioradialis for all fractures which are more than 10 days old, and if I'm going to do columnar plating. The reason for these fractures which are more than 10 days old is that because there's myostatic shortening of the brachioradialis, and unless you release it, your fracture length will not be restored. I usually release it subperiosteally, like shown here, until I see the tendons of the first dorsal compartment, and brachioradialis has a very broad attachment, it's about 11 by 15 millimeters. Only after you released it fully, and I put in a blade here and erase it subperiosteally. I don't put a pair of scissors because I don't know what the tip of my scissors is cutting dorsally. So I do it subperiosteally, staying on the bone, which is very friendly. The other way to restore length is by using this articulated tension device that's shown here, which I use in some situations, or you can use these lamina spreaders or an external fixator. And I use them for all high energy fractures, or if there's extensive comminution, or in cases where, as I said before, nascent malunion. You have to combine this, of course, with the brachioradialis release. For those of you who have used this tension device, it can be applied to get compression or get distraction, as shown in these two pictures. And all you have to do is either engage. So this little hook, it swivels, and depending on which direction the hook is pointing, if it's pointing towards the screw hole, it compresses. If it's pointing away from the screw hole, it distracts. It's a great tool to get length back. Another way to get the length back is to fix the plate distally with multiple screws and then put a screw proximal to your plate and use a lamina spreader and distract against it. And at the minute you get the length back, you'll see there's a hiatus from the fracture fragmentation, and you fix the fracture at length with screws attached to the proximal holes in the plate. You can then graft this if you decide to. So going back to a guy who fell off the roof, this is from many years ago, and we didn't, by the time we saw him, it was more than a day or so. So we decided to take him to the OR, and we applied in those days an external fixator. And now let me see why this is not advancing. There we go. Once you put the external fixator on, now you get a sense, okay, we got our length back, we got our parameters back, but the fragments are very small and very distal, and it's going to be challenging to fix these with any kind of monoblock plates that we have available now. So this is a good situation where you need to be aware of what hardware you have, as alluded to by Dr. Bharadwaj and Dr. Gupta. We have a plethora of implants, and knowing what each implant does and how it addresses the fracture fragments is really critical to know when to apply it. In the days that we did this fracture, we had only this plate available, and the beauty of this plate is that it can be applied far distally on the distal radius, and the screws angle back about 5 to 7 degrees. This was in the days before we had variable angle screws, and that's why this plate was ideal. Now you saw that there was extensive comminution on the radial styloid, therefore I added a column plate on the radial side. So this is a good paper to look at because it teaches you which implant to use where and why it's designed the way it was and how to apply it. Another way to get length back is to also do a plate-assisted fracture reduction. Plate-assisted fracture reduction is a tool to be utilized largely in the young person with good hard bone, or if you have a nascent malunion, which is 6-7 weeks old and you want to get length back in hard bone. And the key is when you apply this plate, you have to make sure that the plate is fixed to the distal radius, not with locking screws. This plate has to be applied with non-locking or friction-based screws so that the plate attracts or attaches to the distal radius flush with the bone. Only then, when you bring the plate down to the bone, will it take your distal fragment and incline it. What do I mean by that? Let's look at this. So if you look here, you will see that there's a faint yellow shadow here. The plate should be attached to the distal fragment with friction screws, and it should be pointing off ulnarly. When you bring the plate radially, as shown by this red arrow, you will get length restoration back. And the reason for doing that is oftentimes you won't get your length back enough because the ulna stops you from ulnarly deviating the distal fragment. So by cranking on it with the shaft of the plate, you get your radial length back, and when you bring the plate down to the shaft, you get your volar tilt back, as shown by the red arrows. So plate-assisted reduction is a good tool to be utilized in young hard bone, not in old osteopenic bone because it will pull out. Always fix it distally with at least 2, if not 3 screws which are friction-based and not locking, and only then can you bring the plate down and restore reduction. How about something like this? This is another way of using plate-assisted reduction. This is a high-energy injury. It's a gunshot wound. There's so much comminution. And the best way to address this is not with an LC-DCP because you barely get 1 screw here. But you can use these plates. You fix them distally and use the handle of the plate or the shaft of the plate to push the distal fragment as shown by the red arrow. And once you restore your DRUJ, you can check it on the C-arm, attach a plate application clamp, and merely fill in the screw holes. That is all you need to do, where you use the plate as a reduction tool. Sometimes all this is not adequate, and because you can't get enough radial length and enough tilt because the ulna is intact and doesn't allow you to get that back. In that case, you can move the radial shaft in a radial direction because that also will give you your length back. But the key is, before you do that, the volar ulnar corner of the fracture must be cleared of all soft tissue and of any early callus. Let's see an example of this case. This was a case being done by someone else while I was in another room. And you can see that the fracture has been reduced, but not completely. You can see that the radial length has not been restored. More importantly, the DRUJ is incongruous. So once this was fixed by another person, they realized that when they tried to supinate and pronate the forearm, there was clunking, which means the reduction was inadequate. At which point, we took the plate off, and when I was asked to help, We took the plate off, we cleared the volar ulnar corner, and then applied this clamp, which you can see here by this broad red arrow. This clamp pulls in a radial direction as shown by this arrow, and at the same time pushes the proximal fragment dorsally. By pushing the fragment dorsally, you restore volar tilt, and by pushing the proximal fragment radially, you restore radial length. As you can see from the circle, we have restored radial length, and the ulnar cortex has also been completely restored. What do these circles show? These circles show that even if you have a small plate, which is only 2 holes, you can oftentimes put 2 screws in the oblong hole, a locking and a non-locking screw, to convert a 2-hole plate into a 3-screw plate. And that's a good trick to remember. How do I maintain reduction after acquiring it? I maintain reduction by putting in wires. For those of you who worked with me have seen that I usually put a reduction wire from the radial styloid pointing dorsally. I usually use 0.062-inch wires. I make an incision there. I separate the tendons of the first dorsal compartment, protect the radial sensory branches, and I use the wires only using an oscillating attachment. So none of the soft tissues get wrapped around the wire. And don't forget the bare area, which you can utilize to your advantage. So why do I not use a thinner wire, such as a 1.1 millimeter wire? Why do I use a 1.6 millimeter wire? I don't use a 1.1 millimeter wire because, as you can see, in young hard bone, it simply bounces off the cortex and becomes intramedullary and doesn't act as a good reduction tool. A 1.6 millimeter wire, on the other hand, holds reduction very predictably in a nice manner. So I prefer to use the 1.6. Occasionally, what you're going to find that in this person who's elderly, you can have a fracture which is a transitional lesion between a distal radius and a Galeazzi. What can happen in these situations that you can have unforeseen combination in the radial styloid, and because this fracture is so proximal, this angle of insert for a traditional reduction guide wire may be so steep that it'd be difficult to achieve. In that case, why don't we make use of this good bone that is sitting there in the intermediate column, and we already got the shaft exposed? So why not put a wire from the shaft proximally to engage the intermediate column distally? This is another way of achieving a provisional reduction, and then it becomes just a matter of achieving reduction and holding it with the wire, and plate application becomes very simple and straightforward after that. The wire is removed. So a good way to remember how to put in a reduction wire is to do it this way also. How to fix the plates distally? Well, I usually fix the plates distally unless I'm doing a distal fragment first fixation technique. I use only smooth pegs, and I don't measure them anymore. This is my cheat sheet, which I'll show you. And we published about this a few years ago, where we decided whether we fix distally with 1 row of screws or 2 rows of screws. And what we found that I was a 2 rows of screws kind of person. David Ring fixed them only with 1 row of screws. Our outcomes clinically were very similar, but radiographically, 2 rows of screws gave a better radiographic outcome as compared to 1 row. However, it did not reach statistical significance. Now, this will be online, so you'll be able to use this cheat sheet. I don't measure screw lengths or peg lengths anymore. I just use this cheat sheet. This is for men and this is for women. And you can use them either in the distal row of the synthese plate or in the proximal row of the DVR plate, whichever one you happen to use. The DVR plate distal row takes only 16 to 18 millimeter pegs. Now, these are broad guidelines, mind you. You don't have to have it exactly right. And you might be thinking, why am I not making it perfect? Why am I not engaging the dorsal cortex? Well, because we know from data that you don't need to engage the dorsal cortex. If your screws are pegs are about 4 millimeters short of the dorsal cortex, biomechanically, the bending resistance is just as good as achieving dorsal cortical purchase. More importantly, in trying to achieve dorsal cortical purchase, you may actually hurt the extensor tendons if your screws are prominent or if your drill goes through. And finally, you have to remember that these are fixed angle devices. When you lock the screw into the place, it's a fixed angle device. A fixed angle device is designed only to provide subchondral support. It does not need to be bicortical. So do I always rely on monoblock plates, or do I also use columnar fixation? I use columnar fixation about 10 to 15% of the time, usually for very distal frown-shaped fractures of volar comminuted Barton fractures. Now, you have to remember the basic principle of surgery. When you're working in a bone that is deep surface and superficial surface, always make it a point to fix the deep aspect first. That means you fix the intermediate column first and then come to the radial column. I don't make any separate approaches. I'm comfortable putting my radial column plate through my volar approach, just like I put the intermediate column plate. So through one approach, I can get both plates on, as I'll show you. So here's this fracture, which is a very, very distal, what I call frown-shaped fracture. And you may think that you may be able to fix this with a volar monoblock plate, but remember, we talked about the watershed line, and you may not get adequate purchase, and your plate may be too prominent. So this one would be ideal, where you fix with an intermediate column plate first, and because this has a distal radial styloid fragment, as we described in the Malone picture, where there are 4 predictable fragments, I fix the radial styloid fragment or the column with a radial columnar plate. And you know, you can get very predictable, very reliable outcomes if it's done in a stable fashion. What do we do with a fracture that looks like this? The first order of business is, even if you got a CT, it really doesn't tell you much. It tells you we got a lot of fragments. So you restore length. We use the tricks that we talked about. Because this was so comminuted here, the styloid, I went with the reverse reduction wire. I applied the monoblock plate, but you can see that I'm not happy about this radial styloid because it is so comminuted, as you can see here. So in addition to a monoblock plate, I added a radial column plate. And you can see you can place it right through the same exact incision on the volar side. You restore good articular surface here, as well as in the lateral view. Now, this is a unique pattern. This you could call this a volar radiocarpal dislocation or an extreme version of a volar Barton. If you reduce it, you realize that this is really affecting the radial column largely with very little involvement of the intermediate column. So to use a monoblock plate for this was, to me, a little inappropriate, and I felt this radial column need to be supported. But again, you have to be prepared for your findings intraoperatively. So when we got in there, this fragment pattern has been described by Greg Bain as the volar oblique pattern, and this one can be fixed with columnar plates. So I fixed it with the columnar plate only to realize that my volar lunate facet fragment was indeed a separate fragment that came in all the way here, but it was undisplaced. So rather than leave it alone, I merely buttressed it with an intermediate column plate. And again, the buttress function does not require screws, but you just put the plate and push the fragment back into place. And here he is at about 3 or 4 months doing very well. Sometimes you may not have a radial column plate available, and it may have to be so long that you can't neutralize this fragment. In addition, if you were to fix this with a fixed angle device like we've done here, these screws are not going to counteract the axial compression forces in this manner. So you have to put an anti-glide plate or a screw. In this case, the anti-glide plate was not available like we do on a lateral malleolus. So I chose to use an anti-glide screw. And in this case, I used a headless cannulated screw, which provided that anti-glide force. And there she is. So we know when to go columnar. We know how to do this through the same approach volarly. But is there a situation where I might go dorsally? Yes, of course. But it's very uncommon. I would say maybe 5 to 10% of the time. And that's usually when the die punch fragment, which we talked about, involves more than 30% of the DRUJ articular surface, and where I am not confident that I can get adequate purchase from my volarly placed pegs. I also use this for scaphoid impression fractures. Now you see this cannulated screw, which is headed and has been used with a washer. This screw is an excellent tool to remember. When you add a washer to a headed screw, you basically are creating a one-hole plate. Finally, you also have to remember threaded K-wires. Threaded K-wires can be inserted at low torque, not at high torque, low speed, and once you achieve bicortical purchase, you merely cut it flush with the surface and it acts like a small headless screw. So we analyzed this, and what we found that there is no consensus among surgeons about when to use a dorsal approach. And it largely relies on surgeon familiarity with the dorsal approach and surgeon discretion, which is not a very good indicator. That's why I use these indicators as my guidelines to use dorsal approaches. So let's look at this. This is a very distal fracture. You can see that the die punch is about half the articular surface, and it's the frown-shaped fracture. The styloid is small, the lunate facet is small. So in this case, I chose to do this through the columnar approach, and I went dorsally and added a second plate. Now, she is older, she's got osteopenic bone, so knowing how to take care of osteoporotic fractures means you have to be familiar with hardware and hardware placement. Finally, the one thing I would say is that just because you have monoblock plates available doesn't mean every fracture should be fixed with a monoblock plate. Even when you place plates the way I just showed you, you can get such outcomes very reliably and predictably as long as you have stable fixation. In this case, this is a younger person. You can see that the die punch fragment is about 50 to 60%. Again, when I fixed this, I was reasonably happy with the overall fixation, but I felt that for the size of the fragment, just having these two pegs from the volar side would not give me adequate fixation in this young person who's high demand. So I made a small incision dorsally, and I put this cannulated headed screw into the dorso-ulnar corner to give me predictable fixation. Now, this is a fracture pattern which does not get a lot of scrutiny. It looks almost like the scaphoid has created an impression on the distal radius fracture, or you could call this a scaphoid impression fracture. Some of you may be inclined to call this a dorsal Barton, which is not unreasonable. They have similar characteristics, but we can differentiate them in the next few minutes. What you're going to notice is the volar cortex is completely intact. So knowing when not to use a volar locking plate in this situation becomes really critical. Here you see the dorsal cortex has sheared off completely, the volar cortex is completely intact, and there's a predictable styloid fragment. So these fracture patterns have very, very predictable patterns. Again, much like we discussed, where the ligaments are attached, you don't get fracture lines largely. Where the ligaments are not attached, you get predictable fracture line propagation. So this is a situation we approach dorsally. You support that sheared off fragment with the dorsal plate. You support the styloid with a cannulated headed screw with a one-hole plate. And like I said before, if you put a screw from the styloid, have it facing dorsally so as to get maximal purchase. And there she is at about 4 months, and she went on to have even greater range of motion with passage of time. This is someone who fell just outside our hospital when she was coming in for cystoscopy. And by the time she came to see me, she had already had a cystoscopy. Now, what you're going to see here, again, volar cortex is completely intact, but the scaphoid has punched into the radius. This is the scaphoid impression fracture. And depending on the position of the wrist, whether it's radially deviated or ulnarly deviated, the size of the fragment is decided by that impression. So this is not something you will approach with a volar lock plate. You approach it dorsally. This dorsal fragment that you see here, you open it up like a trap door, or what I call a manhole cover, as shown by this green arrow. You can elevate the punched in articular surface, and you add a bone graft substitute. In her case, she had a recent cystoscopy. So I was concerned about adding in bone graft or allograft, and I chose to use inert material, and I used a bone substitute, Norian, instead. Because I didn't want to leave hardware in someone who had a recent cystoscopy, I chose to use simple K-wires, which I could pull out if necessary. And you can see we restored the articular surface in both views very well without the need for any large implants. Here's someone who fell playing cricket, and you can see the entire scaphoid has gotten punched into the distal radius. And again, the volar cortex is completely intact. You've got a styloid fragment. Same exact approach. You can see the large articular defect and impression, volar cortex intact. Same approach, we fixed the styloid in this case with wires, and we restored the articular surface by bone grafting behind it, and I used allograft bone chips. Now, sometimes these scaphoid impression fractures can occur in significant degree of ulnar deviation, and the proximal pole of the scaphoid punches into the radius. You may be inclined to look at this and say, hang on a second, that looks pretty darn good. Let's treat it non-operatively. But beware of these fractures. And if you get a CT scan, you're going to see that the articular defect is punched in quite a lot. And you can see the proximal pole has created an impression. And if you look at the 3D, you can see where the articular defect has been created. The approach is same again. You approach it dorsally, you elevate and graft it. And I simply supported the grafted surface with the screw placed through the styloid, which took care of the problem. The screw could have been a couple threads shorter, you could say. But here he is with a reasonable outcome at just about 3 months. Finally, we have to also look at the lunate facet. How do I approach the lunate facet? I usually use the extended carpal tunnel release approach. And you have to remember that if you put a bump behind the hand, it relaxes all your flexors and the median nerve, so you don't have to crank on them too much to get the approach. And we published this again in this paper, which is gives you all techniques to approach the lunate facet. Now, the lunate facet, as we said, extends volarly, ulnarly, and distally. So it has predictable fracture patterns. It may either look like this shape of a boomerang here, or it may have a club shape, or it may have this, what I call the sliver. Always, these fracture patterns are predictable and usually one of these 3 patterns, but you have to be aware of them. You have to look for them. So when I approach these, you have to remember that why do you want to approach them? Why am I emphasizing the lunate facet so much? Because if you don't fix it, what can happen is that because of the attachment of the short radial lunate ligament to the lunate facet, when the fracture fragment displaces, it's going to take your carpus with it. So having this knowledge and fixing the lunate facet fragment is very critical. So here's someone, this is a nurse who fell from a standing height. She has pre-existing radioscaphoid arthritis, as you can see here. She was told that she had a small fracture. When she presented to me a few weeks later, you can see that her teardrop angle in the X-ray on the right is already increased. And if you look at the CT, you can see that the carpus is already subluxing with that fracture fragment. So in this situation, I use an extended carpal tunnel release approach. I take my flexors and my median nerve shown here radially, and I keep my ulnar neurovascular bundle ulnarly. You flex the wrist with the bump behind it to avoid too much traction on the median nerve. And now you're looking at your pronator quadratus. The problem is when you look at the pronator quadratus, it is very difficult to see where the fracture is. So what you do is you run a freer along the ulnar border of the distal radius, and you will feel the small step off of the cortex. That's when you know you hit the fracture. You then develop the fracture, and when you bring it back to length, you get this boomerang shaped defect. You then graft it and you fix it. In this case, I use the headed cannulated screw as a one-hole plate. You place that screw through here, there's the guide wire going through. I always push my guide wires through and I grasp them with a hemostat here so that they don't pull out when you drill. You then drill it and you fix it over a washer, so now your fragment is supported back in length. But if the fracture is old, you cannot rely on one screw only. So you neutralize it with a plate that is applied as a buttress, as shown here. And here she is at 9-year follow-up when she came to see me for another reason. And you can see it's a durable outcome, which is excellent. Now, you can sometimes see these volar marginal fractures also, which will be comminuted. Now, traditional teaching has been a volar Barton or volar marginal fracture is usually one fragment. We looked at about 45 of my cases, and we found that it is almost not the case most of the time. About 3/4 of the time, the volar marginal fracture is multifragmentary, and about 3/4 of the time, there is some element of articular depression. So in this situation, I thought I could get away by doing a standard FCR approach, only to realize after fixing the fracture, or when I approached the fracture, that my lunate facet was a separate fragment. Now remember that if you see a volar Barton, be prepared to look for the lunate facet because it might be a separate fragment 75% of the time nearly. Now I was committed, so what did I do? I did subcutaneous dissection, I found my median nerve, and I went ulnar to it. So I was looking down at my fracture from the ulnar side, and I fixed it with the headed cannulated screw so to support my volar lunate facet, and I neutralized the rest of the fracture with the standard plate. You can see the yellow arrows are showing a headed cannulated screw, and the rest of the fracture has been neutralized with the monoblock plate to give you a predictable outcome. But you've got to know what to look for. What the mind does not know, the eye will not see was an old saying my grandmother used to tell me, and this is an outstanding example of that. So the next question is, how do I address really, really small fragments? Well, really small fragments are a common component of radiocarpal fracture dislocations, and you're welcome to read these to analyze, to understand these fractures. So here's someone who was involved in an MVA, and this you might be tempted to think is merely a dislocation, but this is a very predictable pattern of radiocarpal fracture dislocation, where there's a styloid fragment, and the volar lunate facet has been avulsed. How do you know that? Because I got a CT. You can see the fragments really small. Now here's my mantra. Small fragments mean small implants. You cannot use long implants or large implants for these small fragments. You cannot go monoblock plate. You have to go fragment specific. You have to understand fragment geometry based on your columnar theory. So we approach this the similar way as I showed you before, and I use suture anchors to restore this fragment. I fix the radial styloid with a screw, and I fix my dorsal cortical fragment, which you can see here, which was fairly large, with another screw. And there she is with a very reasonably predictable outcome. And you can see my extended carpal tunnel release approach here. These are other tricks that you can utilize to fix this volar lunate facet fragment if it's really small. This is a technique that I borrowed from sports medicine colleagues, where you put a suture through the short radial lunate ligament, and you put a 2.7 or a 3.5 millimeter screw here as a post, and you tension band it around the post, and it works remarkably well. You can also use small screws to fix this volar ulnar corner. Now, do I plate all fractures? Of course not. I do have some of them that I pin, about 10 to 15% of the time, but I largely reserve it for extra-articular fractures or for very simple intra-articular fractures in young people. I then cast them for 6 weeks, and we have compared these outcomes and published them. And what we found was, if you compare fractures exactly and you plate them or you pin them, outcomes at 6 months are very similar, and there's no advantage to either technique. If you compared outcomes at 6 weeks, obviously the plates are doing much better because the pinned people are still in the cast. Now here's the kicker. The cost of pinning a fracture was about $10 to $12. The cost of plating a fracture was $1,600. And the OR time was 23 minutes versus 75 minutes. So you have to take all that into account, especially in resource-poor environments. But you have to follow the principles of pinning that we outlined before. And if you do that, you can have very reliable outcomes. So here's this young lady who's a student at the time, very comminuted fracture, young bone, but predictable patterns. Look at that. We've talked about the 4 fragments that you see as described by Malone. You constantly see the same 4 fragments. But because it was young bone, I felt that we could pin this. More importantly, the patient did not want to have a plate. So we pinned her with pins placed through the styloid as well as through the intermediate column. And you can see we've restored our radial parameters. We've restored the volar tilt. And she was casted for a few weeks. And here she is at about 3 months with a reasonable outcome, wearing a wonderful scarf that says Om. So sometimes you can have patients who don't want pins and casts because they are claustrophobic. They do not want the concept of having large plates in their bodies. What do you do with such patients? Well, again, like I showed you, be prepared to use the one whole plate. And this is a good alternative that can bail you out. So here's someone who had this very distal frown-shaped fracture. You can see that the fragment geometry is very reliable, very predictable. So in her, we just used a radial styloid screw, which is cannulated. I didn't use washers in this. And we got this cross fixation. You can see the styloid screw headed dorsally and the dorsal screw headed volarly. So we got all 3 planes were neutralized with very minimal fixation. And the patient was happy because she had very small scars. And here she is. This is just about 6 weeks down the line with an excellent outcome. The next question I get asked is, when do I do carpal tunnel release? As I've gotten older, I do more and more carpal tunnel releases because I feel that they improve decompression of the hematoma within the carpal tunnel. They also allow excursion of your long flexors and help you get motion of your fingers back much faster. More importantly, if patients have impending carpal tunnel syndrome, especially in women over the age of 60, then decompressing the carpal tunnel makes a huge difference to your outcomes. I use it for all high energy fractures, or if I'm excising the hook of the hamate, or if they have any pre-existing symptoms of carpal tunnel syndrome. I get asked, have you had any patients with reflex sympathetic dystrophy? And I can honestly say that this is one thing I've done which has really helped me in minimizing, if not completely eliminating, the possibility of RSD in my patient population. And we published this where we found that surgeons are agreed in decompressing median nerves in patients with high energy injuries, But otherwise, we find that surgeons don't have distinctive guidelines of when to decompress median nerves. So my guidelines are the ones that I showed you just before. All patients with high energy injury, all patients over the age of 60, especially women, or with pre-existing carpal tunnel syndrome. Now, the next question I get asked is, can the wrist be span plated? Of course you can span plated. Here is someone who came off a stair at a very big height, and he had these multiple fractures of the radius and of the metacarpals. So in this case, we fix the radius with screws because they are small fragments. We fix the metacarpals with plates and an intramedullary cannulated screw and span the entire construct with this plate. We maintained this plate for just about 3 months. And when we took the plate out, you can see his outcome is pretty reasonable. He had a very poor scar, but other than that, his outcome was very, very reasonable. So the last thing that we will cover is the options for the ulnar fracture, which is a commonly asked question. Now, this is my algorithm. If you have an ulnar head or neck or a distal shaft fracture, if it is undisplaced or if the radius is being treated non-operatively, then I leave it alone. If I'm fixing the radius, then I will fix the ulna in the young person. But in the elderly, you have two other choices. You can either treat it non-operatively, or if it's very distal and osteopenic bone, you can also do a primary excision of the distal ulna. But that's a really, really minimally utilized option. So here's someone who has this fracture. She is older, but she has a Galeazzi variant, and her distal ulnar fracture is very oblique. So in her, I chose to fix it. She went on to form a fair amount of heterotopic ossification, but surprisingly, she had an excellent outcome in terms of forearm rotation. Now, this is a young person who fell outside on the ice, and you can see that even though she's young, her bone quality is not the best in the world, but she has this very distal ulnar fracture. So because she was relatively young, we chose to fix it with a monoblock plate for the radius and also fix the ulna with this wraparound plate around the ulnar head to get more than one plane of fixation. And there she is with a reasonable outcome. Can the distal ulnar fracture be left untreated? And yes, there is increasing data to show that you can leave it untreated. Here's a paper that I've quoted from Namba and colleagues, but there's also a paper that came out of our own institution a few years ago, which shows that in the elderly over the age of 65, it is often okay to treat the ulna non-operatively, provided after you fix the radius and you check forearm rotation, the ulna moves as one unit. So here's someone, she's about 70 odd years old. You can see she has a displaced distal ulnar fracture. We fixed the radius and we left the ulna alone, which went on to heal predictably. And that's her outcome at about 3.5 months. How about primary ulnar resection? I don't encourage this. I don't really do this as a routine, but sometimes you have to keep it in your back pocket to think about. If there's comminution, if there's osteopenia, if the patient bone quality is really poor and won't support hardware, then I fix the radius and can excise the distal ulna. You can see that there's data to support this as well. You can get good to excellent outcomes in nearly 90% patients. So here's someone, this ulnar fracture doesn't look too bad, but look at the cortex, very, very poor, really poor quality bone, and even the radius was very osteopenic. So once I fixed the radius and I tried to fix the ulna, as you can see from these holes here, I realized quickly I had no fixation in the distal portion of the ulna. So I chose to excise it and did a ECU tenodesis, and she went on to have a predictable outcome without any pain. So finally, what I get asked about is, when do you fix the ulnar styloid? Well, let me dispel that notion. In my opinion, ulnar styloid needs fixation less than 1% of the time. There's multiple series that have looked at distal radius fractures with ulnar styloid fractures, and they found that the location of the styloid fracture is irrelevant to outcome. No effect on outcome if left alone. There may be a slight reduction in flexion and ulnar deviation and grip strength, but this is not of any statistical significance. The papers that have been quoted on the right are supporting of this theory. So for me, what do? I assess the fracture geometry with the CT as needed. If it's a styloid tip fracture, I leave it alone anyway. If it's a base fracture and I'm treating the radius non-operatively, I leave it alone. If I open the radius, then I fix the radius and I assess DRUJ stability. If it's stable, I leave it alone. If it's unstable, then I consider one of two options, which I'll show you. So here's someone, motocross rider, high-speed motorcycle accident. You can see that the ulnar styloid fracture is very proximal. We fixed the radius, and the patient also had a hook of hamate fracture. So we fixed the radius and we checked for DRUJ stability. The next question I get asked is, how do I check for DRUJ instability? And what has been popularized is this test, where you compress the radius and ulnar together, and then you shuck it. I would say, please, 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 this test is very, very unreliable in my opinion. When you have a patient under anesthetic and they don't have any muscle tone, you can take an ulna and make it shuck in almost any patient. So to me, this is largely unreliable. So what I simply do is, I take the patient's wrist and hold it between my two palms, and I rotate the radius. And with the palm, I feel if my ulnar head is translating too much or not. If it's not translating, I am done. When you restore radial length with a volar monoblock plate or with any other devices, once you restore radio-ulnar contact, the contact forces will keep your ulnar head in place. So in this motocross rider, that was not the case. So we fixed the radius, we got all sorts of devices in, and I put a small tension band around the ulna, which restored stability. Now that is great, and there's his outcome, which is spectacular. But what happens if the DRUJ is unstable, but there is no ulnar styloid fracture? Now what do you do? So here's a physician who fell on the ice, and you can see that the radius is completely translated. And we fixed his radius. You can see there's no ulnar styloid fracture. Now, should you open it and repair the TFCC? Okay, that's one option. Or in this patient who has a very dysmorphic DRUJ and a type 3 DRUJ as described by Amit Dolat, then I chose to do something a little simpler. I could feel his DRUJ reducing at neutral, and I felt that was reasonable. So I merely pinned the distal radial joint proximal to it so you don't violate the articular surface, and I held him at neutral for 6 weeks. And he went on to have an excellent outcome. So that is how you address the DRUJ. So in summary, what I would say to you is, don't look at the radius as one big block. Think fragments, think columns. Radial styloid, die punch, volar lunate facet, ulnar column. We have covered all of these, and I've given you strategies of how to approach each of these. More importantly, don't use one plate for everything. You titrate the implant to the fragment. Remember the mantra, small fragment means small implants. And finally, if you have an intact volar cortex, do not fix with a monoblock plate volarly. Oftentimes, it needs a different strategy to fix that fracture.